Well, nice to talk to you all. I was asked to talk about basically part of the procedure that I do. And the title of the talk is nasal maxillary expansion. Not all are created equal. I'm sure your members have do a lot of myofunctional therapy and et cetera, and sees patients with sleep apnea and all sorts of sort of dental facial issues. So let me just get started. Now I'm going to talk about nasal maxillary expansion. Typically, the indication for the procedure is as follows. The treatment of crossbite has been a traditional indication for maxillary expansion. More and more, the treatment has become the treatment of nasal obstruction and the treatment of sleep apnea. Okay, so those are my three sort of indications to consider the operation. Now, you are probably going to be, this is going to be a little different maybe compared to what you've heard before. In my book, the goal of maxillary expansion is to enlarge the nasal airway, okay? If you're to treat the airway, i.e. breathing or sleep, you want to separate the mid-palatal suture. The maxillary widening is just a byproduct in terms of what I'm trying to do. And maxillary expansion of the dental or dental alveolar region, it may improve the resting posture of the tongue during the day, but it does not improve breathing or sleep. This may be contrary to what you might have heard in the past, but that is my opinion. And let me sort of validate that with some literatures. The nose, nasal breathing is good. Okay, we want to be able to breathe through our nose. It is the nose is the most resistive element of the airway, of the entire upper airway. Represents about 50% of the total airway resistance. Is the most resistive component of the upper airway. If your nasal breathing is obstructed, you're going to have to compensate by breathing through your mouth. It results in increased airway resistance when you're asleep. And when your mouth is open, your tongue is going to reposition posteriorly and actually narrows the airway. Mouth opening with retral displacement of the tongue actually alters the genioglossus muscle and the airway muscle activity, so make the tongue more sort of floppy and collapsible. And if you obstruct in a healthy individual's nose, you're going to induce sleep apnea, both men and women, okay? If you improve nasal breathing, improve the nasal airway, it can improve or reduce the nasal resistance and improve sleep apnea. Now, maxillary expansion really is to expand the nasal vault, the nasal aperture, enlarges the nasal airway, which reduces nasal resistance. And when you do that, it's going to make the sort of improve the negative airway pressure during sleep and improve sleep apnea. Now, the last sort of reference was done on kids, basically studied by Palo, who's an orthodontist from Rome, that when you expand the nasal cavity, and it's basically the result of the maxillary expansion. And it can also improve the nasopharyngeal region. So a little bit about physiology. Now, we breathe at negative pressure. What that means is that it's kind of like drinking through a straw. We expand our lungs, we generate a negative pressure to suck the air into our nose and our mouth. Okay, that's how we breathe. When there's nasal obstruction, your brain or brainstem is going to tell you that you have to suck harder to get enough air into your nose and mouth. Okay, so you're going to increase the negative pressure. It is going to cause the compliant airway, which is the back of the throat, the tongue aspect. It's going to cause narrowing and more collapse. Therefore, it's going to restrict your airway, and that's sleep apnea. Now, when you improve nasal breathing, you're going to directly expand the nasal airway with improving nasal breathing, so you don't have to breathe as hard or generate as much negative pressure. Therefore, causes less collapsibility of the back of the throat. That's how this procedure works in terms of improving breathing and sleep. So these are just MRIs when the patient is asleep. You can see that mouth is open, the soft palate is moving, tongue is moving. This is basically sleep apnea. Okay, this patient has sleep apnea, and watching the patient, struggle to breathe during sleep. Now, I know some people will say, well, we're expanding the upper jaw or the maxilla to enlarge the intraoral volume for the tongue. That is false. When we're asleep, our tongue is not, quote unquote, on the spot. When we're asleep, our muscles are relaxed. So our lips may open a bit, our tongue is going to collapse back and sort of retro displace a little. Okay, it does not fill the mouth. We're not maintaining the tongue position when we're asleep because the muscles are relaxed when we're asleep. Therefore, you can see that these patients, now you see the lips are open, the mouth is open, the tongue is not at the roof of the mouth. The tongue is retrally displaced. A bit of the sleep study. I'm going to go over just a little bit of the PSG, which is an in-lab sleep study. Now, what we're seeing is this patient is breathing through the nose, and there's some air exchange. You can see the patient snoring. I'm just going to be quiet so you can hear it. You can see there's some obstructive breathing. The patient's actually, the mouth is open, which we could see on the videotape of the patient during sleep. And the patient is actually breathing partially through the nose and through the mouth. You can see the snoring happening. Another video, you can see that patient's snoring and actually obstructing. You can see that there's minimal airflow through the nose. The patient's is snoring. Okay, there's some mouth breathing. No nasal flow, some oral flow, which is registered by the thermistor. So during sleep, we can alternate in terms of nasal breathing, oral breathing, or a combination of the two. In this sleep study, you can see that there's some nasal breathing, there's minimal oral breathing. Nasal breathing stops, oral breathing starts, okay? Then you can see oxygen start dropping, and then a little bit of arousal, nasal breathing starts, and a bit, and oral breathing takes over. So it kind of alternates a bit back and forth, and there's snoring that's happening. You can see that in this other PSG, you can see nasal breathing. When it transitions to oral breathing, it's not an efficient way to breathe. Therefore, you can see that there's oxygen desaturation. This happens all over and over again. Okay. Now, what are we doing with nasal maxillary expansion? We are trying to expand the maxilla, open up the mid-palatal suture, and enlarge the nasal cavity to improve the nasal airway and breathing. Early history of a rapid maxillary expansion. These are basically mostly from kids. Peter Satuli is a pulmonologist from Australia. Peter was the first to report validated improvement of sleep apnea based on sleep studies with maxillary expansion. Palo, as I mentioned, an orthodontist from Rome, and she's done a lot of work on rapid maxillary expansion or palatal expansion in children and demonstrated that the procedure improves nasal breathing and improves sleep apnea. I've done a fair amount of work on maxillary expansion. Back in the days, this was almost 20 years ago, I was doing a lot of expansion in maxilla and the mandible. I was basically, these are slides from Palo. So you can see that this patient was a child, obviously, had bilateral crossbite. The maxilla is very narrow, and the child underwent maxillary expansion, but you can see that expansion. Here's the alveolus. You can see the alveolus is expanded and rotating outward, okay? So what happens in majority of the maxillary expansion cases is that most of them are actually dental tipping only 40% are actually opening up sort of the skeletal aspect. The rest are basically alveolar or alveolar dental. We're just sort of widening the mouth. Not real, and there's more mouth sort of manipulation rather than nasal manipulation. And as we see that in patients when they get older, most of the changes are really dental, a lot less skeletal. Why? That's because as we get older, our skeleton becomes stiffer, suture becomes more sort of ossified and bound together. So it's much harder to manipulate bone or the skull. And the hardest part to sort of open, to separate, is the posterior maxilla. Okay. Recent years, MSE or MARPE has become very popular. The concept is that you can improve the skeletal anchorage and improve the bony changes or skeletal expansion. But you can see from the literature, majority of the changes remains in the dental aspect or dental alveolar aspect. You can expand the molar, at 5 millimeter, but you may only change the nasal width 1.4 millimeter. You can see that this is very consistent in the literature. So most of the expansion, even with the MSE or MARPE, it's dental. It's been demonstrated. But if you believe that what we're doing is expanding the jaw to try to improve the nasal airway, you want to maximize the skeletal changes and not have all the expansion be primarily dental. Again, expansion of the mouth does not improve sleep apnea. So let's look at some cases. This is a 20-year-old from Canada came to see me. These photos are not the greatest quality because they were handed to me by the patient. I don't have the original photo by the person who did the procedure. You can see that the MSE has been maximally expanded, okay? But there's no change. If you take the CT scan, you can see that there is no opening of the mid-palatal suture. Basically, the expander widened and tilting the screws. The procedure is ineffective. Here's the mid-palatal suture. There's no change. And this patient is only 20 years old. This is a 34-year-old orthodontist from Southern California who came to see me. You can see that the palate is very narrow. The MSE is basically burying into the soft tissue. The sort of screw looks bent. And you can see that the appliance, the arms were cut because it was digging into his tissues. You can see the mid-palatal suture remains closed. This is a 22-year-old from London, from England. He came to see me. You can see that he had the MSE, where the MSE basically, without opening up the mid-palatal suture, it is just basically expanding into the soft tissue, causing destruction of the soft tissue. Patient from New Jersey, failed one, then put a double expander in there, still unable to expand on this 30-year-old with sleep apnea. Patient from Connecticut, I could see you photos after photos after photos that MSE fails in young adults. We're not even talking about middle age. Here's another case where there's no change, and the MSE basically just digging into tissues and cheese wiring. The screws are cheese wiring through the nasal floor. So why does that happen? It's because starting from sort of late teens, young adults, the skeleton is very stiff. Sutures, even if you add 4 microscrews. What about other type of maxillary expansion? This is a 16-year-old who had ALF treatment for 4 years. Now for this group, you can see that she has an open bite. Obviously, she's a tongue thruster. Okay, that's ALF. ALF is just a single wire, and people believe that it's going to widen the jaw, and a lot of people are going through this for the treatment of sleep apnea. You can see the pre and post CT scan. there's no change in the mid-palatal suture. All you're doing is basically flaring out the teeth, making the sort of jaw a little wider. It does not change the nasal airway. And she had no improvement in sleep apnea. This is a 57-year-old with moderate sleep apnea. She went to have this appliance, special appliance made. And this has become very popular. I told her that it's not doing her anything because she's not noticing any symptomatic change. And you can see that she had prior MMA surgery a few years ago, not by me, but her sleep apnea has gradually worsened. You can see that mid-palatal suture remains intact. All the appliance is doing is basically flaring out the teeth. You'll see this repeated in many, many of the appliances that are being used right now, okay? Here's a CT scan. You can see that the teeth are just being flared out. No change in the nasal airway, no opening of the mid-palatal suture, no, okay? This is a patient from Denmark. She came to see me. She had 8 or 9 months plus treatment of using this device called the AGA. You can see that with this device, the patient's front teeth are being pushed out significantly, okay? All it's doing is basically causing periodontal destruction. The objective of the treatment was to, quote unquote, grow her jaw. Her jaw is not growing. Her teeth are just being pushed out. Then you can see that teeth are just being flared out, pushed out, okay? I could show you cases after cases with AGA. He's a young man. You can see the teeth are being pushed out. You can see the bone that's being destroyed without really doing anything for the airway. Another patient, 20-year-old guy, the teeth are being significantly pushed out, displaced. Pre and post scan, you can see that all the labial bones been destroyed. This patient has, 20-year-old has 6 loose front teeth. You can see that there's no change in terms of mid-palatal suture and just flaring out the teeth. And this treatment goes against all principles of orthodontia, in my opinion. And you can see the same patient before and post, nothing is changing skeletally. There's a 14-year-old that I saw, came to see me, has nasal obstruction and sleep apnea. She underwent 7 years of treatment of appliance to try to grow her jaw. You could see that when she first started versus now, or when I saw her, I don't think her jaw grew much of anything. All it's doing is basically pushing the teeth through the bone, thinning out the bony support. Okay, so there's a lot of treatment. Now, in my book, if you're going to do something, you have to check off 2 boxes. Number 1, it has to make sense physiologically. We know anatomy, we understand physiology, it has to make sense, okay? Number 2, ideally, you want to have some data supporting its use, that it's been demonstrated that's helpful, or has some form of efficacy. Again, I'm going to show this slide over and over again. In many patients, especially teens or older, it's hard to manipulate the skeleton. When you apply pressure onto the teeth, you're just going to push the teeth out, not really affecting the bone, which is what we're aiming for. In the old days, we used to do this procedure because we cannot manipulate the skeleton, but we wanted to treat the crossbite. We used to do this procedure called the SARPI. Now it's been renamed with dome, and regarding it's called dome now, which is fine. So basically the concept is because we cannot manipulate the skeleton, we will make a cut in the midline and horizontally to widen the jaw. This procedure I've done a lot. It was designed to treat crossbite, to widen the maxilla. I was young and foolish back in those days. I thought that we're gonna widen the maxilla. I was so proud of myself, create a huge bite of a huge gap of the jaw, that we're gonna increase the width of the jaw to create space for the tongue. Okay, that was 20 years ago. And at the same time, I'm going to improve nasal breathing. There you can see that jaw has been significantly widened. This is distraction, all those blue bones form. I've done a number of these cases. And back then, we didn't use CT scan, so you could see that the nasal area was improved. And patients, some of the patients' nasal breathing is better. Here's another case. You can see widening of the upper and lower jaw. But the treatment was not very consistent. The results were not consistent. I was not happy with the results that I'm seeing and the degree of improvement as well as the consistency of the results. I started looking at my cases and I see, gee, I'm creating a big gap between the front teeth and it's all in the front, okay? And I'm making these cuts. I'm sort of displacing this a little bit, but really it's all mostly dental changes, okay? And nothing's happening in the back. This is what I call cone expansion. I said, I must be doing something wrong. Then I did a literature search. I learned that all these RPE or SARPE, that's the typical expansion pattern. We are widening the jaw, maybe affecting the nasal airway some, but not to a significant extent. This is another SARPE patient came to see me from New York. He had a big diastema and he said, my nasal breathing is not better. It's been told to me before. You can see that the diastema is created, but there's no change in terms of nasal airway, okay? So we're just widening the jaw, not really affecting breathing, which is what the objective is. Now, people like to call it dome. Well, it's been renamed by many people. So you can see that if we are making a cut in the midline and here, these are releasing incision, and then we apply appliance onto the teeth. We could use some 4 screws with the MSC device. You can see how mechanically, how it's going to widen. It is going to stop here because the cut is sort of slanting down. So it's just going to sort of rotate out the alveolar portion, okay? It's going to rotate outward like this and not really opening up the back at all. That's a typical SARPE or dome expansion. I think dome creates terrible results. This is a patient that came to see me. He had the dome operation. You could see, hey, the diastema is impressive. They're creating wide jaw. But in order to try to expand as much as possible, thinking that you're going to improve the airway, you create a very wide gap. You can see that the cone-shaped expansion. This is 1.5 to 2 years out. You can see that patient has 2 loose front teeth, had to have root canal because the expansion is so large, it went beyond the envelope of the physiologic limitation of healing, okay? He was not better. Then he had the MMA operation, move the upper lower jaw forward, not a very good advancement, had infection, had problems, and then came to see me because he's still not sleeping well. There you can see that the upper jaw is loose, right? The upper jaw is not supposed to be loose and floating. That is called non-union. So he's been eating mush for 2 years. Okay, that's called a non-union after MMA. Another patient, same source, had the dome operation that you can see that significant diastema created. You can see that the expansion pattern, okay? Look at the expansion pattern, huge diastema, a little bit of nasal expansion. This part moved a little bit. This part did not move. Typical cone-shaped expansion. The biggest openings in between the teeth. The least amount of opening is in the nose, okay? Almost 2 years out, still a fair amount of bone defect at this area because the space is too large. The patient is no better, had the MMA operation, not by me. So you can see that after the MMA, here's a position of the lower jaw. You can see the lower jaw position is displacing, the position is changing. Here's the lower border on the left right jaw. You can see the border now is changing. The patient has non-union. The jaw is not healing and the bite starts shifting. You have to have 2 or 3 additional operations. Finally, he came to see me after a number of failed procedure. I had to sort of try to rescue his jaw. And then you can see the bone's dead, which was not removed. That's a piece of dead bone that I had to remove. And the patient, unfortunately, still has sleep apnea, still can't breathe through his nose. And he wants to have more surgery to see if, because he couldn't tolerate CPAP. Another patient with dome, same source. The jaw has been widened significantly. There you can see the pattern expansion. Here's a nasal airway, nasal wall. You can see that this part on the left side is moved a little bit. The right side did not move. This is the mid-palatal suture. It did not split, but it split on the right nasal floor because there are a couple of micro screws there. Then you can see that the asymmetric expansion, displacement of the segment to the left, no change on the right. Okay, this is the end result. Patient's nasal breathing is not better. Sleep apnea is still a problem. Then he went on MMA. Typical story. This is surgery. This is the occlusion before the surgery. 3 weeks later, his jaw became like this. He came to see me for a second opinion. What happened? Well, this is the CT scan after surgery. This is when I saw him. You see the space? Bilateral non-union. Okay, I had to do 3 operations to try to save his jaw. He's still not out of the woods. Another dome, large expansion. You can see the typical pattern. Huge diastema, widening. Here's the displacement, asymmetric expansion on the left, minimal movement on the right, cone-shaped expansion. The patient's nasal airway is not better. And from here, you can see the amount of sort of the bone that did not fill. 1.5 years, 2 years out, and the patient is no better. This is the issue. If you're trying to improve the nasal airway, that's the concept. You make a cut here and you make a cut here. All you're expanding is the jaw, right? Because that's what you're doing. And this patient came in, is a perfect example. You could see that there's such big distance between, you see this gap? That's a non-union of the maxilla, okay? Now, these are sort of 3D CAD design based on a sort of a typical average measurement of the nose. Again, I'm going to talk about the nose because that's what we aim to manipulate. Before treatment, so if we are doing dome, that means that a cut is made across the maxilla. Let's say we widen this 10 millimeter with a cone-shaped expansion. You're going to increase the volume of this entire area 5.5%. Now, if all you do is just you try to expand the front, not the back, you open up the front 4 millimeter. Okay, often that's what I see in the MSE or dome. When they're successful, you get about 4.5%. But if you're able to open up the front and the back, just 3 millimeter, you're going to open up the entire nasal volume significantly. Why is it so dramatic? Because the nose is a very steep pyramid. Okay, going back to freshman geometry, a very steep pyramid, you just widen the base a little bit, you're going to significantly change the overall volume. So ideally, this is what you want. You want to be able to widen really the midface, okay? So you can significantly change the entire nasal volume. This is a procedure that I do. Basically, you want to expand the jaw to manipulate the nasal aperture, the entire nasal airway, okay? Why do I always harp on the posterior aspect of the maxilla? Because when you expand the entire maxilla, including posterior space, you're going to increase the volume of the nasal pharynx. which has been demonstrated in children by Palo. Okay. Why is she able to achieve that? Because the study was done in kids. It's easier to expand kids. All right, I'm going to talk about the procedure now. When I first started doing this, I didn't want to expand the maxilla too much. Why? Many patients came to see me because they continue to have sleep apnea and breathing problem despite prior RPE or maxillary expansion. Some have multiple expansions done already. So their jaw already wide, okay? So I didn't want to create such a wide jaw. It doesn't look good. So I want all the manipulation to be skeletal because my objective was to open up their nose to improve breathing and improve sleep. There you can see before and after. Opening up the mid-palatal suture front and back, you can see that there's really no change in terms of minimal change in the angulation of the teeth. It's all skeletal. I'm widening really what I call the nasal maxillary expansion, the entire midface. There you can see the changes. You can see the teeth are the same. No diastema, really just the bone. Okay. 15-year-old. Now it's becoming a little more difficult to expand, right? For some of the conventional treatment. He still has nasal obstruction and sleep apnea. He had several rounds of RPE. The jaw is already wide, but it's not wide enough, right? So I expanded him. You can see the extent of expansion, bone only, with no shifting of the teeth. Here's a skull. You can see that the entire nasal apertures has been expanded. He's breathing, sleeping much better. Getting even older. This patient is on BiPAP, sleep apnea. Entire family has sleep apnea. He was expanded skeletally. There you can see on a 17-year-old skeletal expansion without a whole lot of or any teeth movement. So I'm not making someone's jaw so wide, but only affecting the nose 20%. It's what I expand is what I get in the nose. There you can see the skeletal expansion without this really destroying the teeth or the dental alveolar aspect. He's not wearing BiPAP anymore. This is a very early study. You can see that the mean age was 13, and you can see improvement of sleep apnea, symptomatic improvement. And I did some airway measurement based on computational fluid dynamic. You can see the significant reduction in the airway negative pressure. So the effort of breathing is much improved. Going back to the physiology of breathing and sleep, okay? We want to reduce the resistance so that the ease of breathing is improved. That's what we're trying to do. I've been doing this for almost 4 years. It's not limited to people that have a prior RP. These are sort of all patients from all walks. They come in with nasal obstruction and sleep apnea. You can see that a little bit diastema is created, but it's not huge. The palate has been widened. You can see the expansion pattern, all skeletal. The nose is opened up entirely. Now you'll say, oh, 10-year-old, that's easy. You're right. It is easier for a 10-year-old, but you see no displacement of the teeth. It's all bone, okay? 14-year-old nasal obstruction. It's self-explanatory. The palate's widened significantly. A little bit of displacement of diastema, but you can see the extent of the bony changes without destruction of the teeth, or you could just see the extent of the expansion, front and back. I'm going to run over these cases fairly quickly because it's, it's self-explanatory. Now we're going to, all ethnic group, boys, girls, you can see he was expanded, a little bit of diastema, 2 millimeters created. You can see the entire bony change, no teeth change, significant opening of the airway with breathing and sleep improvement. This kid could not get out of bed. Problem getting out of bed for school, always tired, grouchy, expanded, and he was he had a great deal of expansion, and parents said it's 9-day difference. You could see the extent of expansion without destroying or altering the oral morphology so dramatically. It's changing, which is what you want because he has crowding, but not creating such a wide jaw while not really helping the airway. You can see before, during, and after. Here's the extent of expansion in terms of we're able to manipulate the airway and the skeleton, okay? Getting older, he has severe sleep apnea. He was expanded. You can see the health of the alveolus. You can see the expansion pattern, front and back. Okay. The nasal airway is dramatically improved. He's better, but he has severe sleep apnea. So I did an MMA on him, and he's much improved. So you can see this, he's my patient, so you can see the difference between this MMA with the prior sort of the complication that I've seen. You can see the nasal airway improvement persists when the patient is getting older, okay? Because I'm changing the skeleton. There's no relapse because relapse often is related to dental changes. That's why orthodontia, you have to have retainers. Getting older, he was expanded. You can see the extent of it. He's about an 8mm expansion on the bone, 7 or 8mm on the bone only, without changing the position of the teeth, not creating a huge diastema, okay? The reason I want to show this photo is that he's 14, has sleep apnea, he was expanded, a little gap is created, his jaw definitely is wider, but not abnormally wide. But you can see the extent of the expansion. The entire maxilla and nasal complex is widened. He's much, just look at the sort of the dramatic difference. Breathing, sleep much better. And the mom's so happy, brought the older brother in. Okay, 17-year-old, he was not a great sleeper. He was ready to take his braces. He already had braces, okay? So he was expanded. You can see on a 17-year-old, same pattern expansion without displacing the teeth so much and not really getting to the root of the problem, which is the nasal airway. So I treat a lot of families. I treat mother, son, daughter, father, because sleep apnea is familial, runs in the family, okay? First degree relative, it's been well demonstrated. Different ethnic group. 13-year-old with sleep apnea. You can see the jaw was expanded. The jaw is wider, but really take a look at the extent of expansion of the bone and the nose, okay? You could go over and girl, expanded. You can see the extent of expansion, but you can see that I'm not destroying the bone of the upper jaw. This is a boy who is a son of a sleep physician from the Midwest. He came to see me. I just removed the device. I want to show you this. This is about 6 months apart. You can see that bones already ossify, right? You can see the extent of expansion. Much improved nasal airway. Now, remember the 16-year-old that had the ELF treatment? She's still symptomatic. I expanded her, okay? There you can see, this was the ELF treatment. After you remove that wire, relapse, the entire teeth relapse back because they're just bending the dental alveolar aspect. What happened? So basically the teeth are in better position where the nasal airway was improved. Breathing, sleep much better. Remember the 14-year-old that had the appliance made that pushed out all her sort of thinned out all the bony support of her teeth? I expanded her significantly. There you can see how much you can expand someone's airway. Much improved, mom's happy. So these are the children. Okay, what happens to adult? Remember I said that when adult becomes adult, when people are sort of in adulthood, much harder to expand. What I do is basically I make sure that the sutures are released and weakened. You could, when I first start out, I release the palatal suture through the nose, and you could do various ways. 23-year-old on nasal CPAP. You can see his jaw has been expanded. He's also a tongue thruster. You can see the extent of expansion. No destruction of the dental alveolar. It's pure bone expansion. Improvement of the nasal airway, breathing, sleep, now much better. 25-year-old from Northern California. You can see pure skeletal expansion. I'm not pushing out the teeth, creating a big gap. What I'm doing is basically opening up the nasal maxillary complex, improvement of nasal airway. There you can see that the jaw's midface expanded. You can see these suture lines all modulating because the entire midface expanded, so I could improve the entire nasal airway. Okay. Not wearing CPAP anymore. 20-year-old, significant symptom of sleep apnea. Both her and her brother has it. You can see that jaw's expanded skeletally, the extent of skeletal expansion. Okay, I'm not pushing out her teeth to create a big gap. The jaw for sure is wider, but it's the bony expansion to create a wider jaw, not flaring out the teeth. There you can see the extent of bony expansion, much improved airway, but she has significant sleep apnea. Although she's better, she was still symptomatic. Okay, there you can see completion of orthodontia. You can see that bone maturation and ossification. She was still symptomatic, so I moved her jaw. And that's a lot of counterclockwise rotation, about a 22-millimeter advancement. You can see that the extent of advancement is quite big, much improved, off to college, no problems. 25-year-old, now he came in really for crossbite. He has some nasal obstruction, but no sleep apnea. There's a bit of a tongue thruster also. But what's interesting about him, I expanded him because the orthodontist was concerned about any form of expansion. Why? These are the length of his tooth root. He had prior orthodontia. You can see a pure skeletal expansion. Those are his tooth roots. Okay, so the orthodontist did not want a whole lot of sort of teeth movement, but it's all pure bone expansion to widen his jaw. And at the same time, his nasal breathing was improved. Getting older, he's about a 6'7". He used to play basketball, big guy, heavy bone. You can see that the expansion was throughout, front and back, significant expansion in skeletal expansion, no destruction of the teeth or create a huge diastema. There you can see it's really a three-dimensional skeletal manipulation. And this procedure is done under sedation. It takes about less than an hour. Outpatient. Okay. Skeletal deformity and sleep apnea. Getting older, you can see he was expanded skeletally, no change in the teeth position, all bone expansion. You can see the changes. You can see the bone is already filling in, maturing, ossifying. This was not even 6 months after the expansion. You can see the maturation of the bone in the mid-palatal suture over time, and no change in terms of bone height or anything. Why? Because I'm not manipulating the area so dramatically, affecting the bone regeneration. You can see before the jaw was narrow, so the teeth were flaring out, right? Now it's sitting much better in terms of in relation to the alveolar aspect. Sleep physician who's on nasal CPAP, can't breathe through his nose, struggling. As a crossbite, I expanded him. 31-year-old, you could see a pure skeletal expansion. His nasal breathing was better, but he still was dependent on the machine and didn't want to use the machine. So I advanced him. You could see that the skeletal manipulation remains the same. Okay, it doesn't relapse because it's bone. And he was advanced, I think, 14, 15 millimeters. Getting older, 32-year-old. He couldn't breathe through his nose for his entire life. Very symptomatic from his sleep apnea. Look at how narrow his nose was. So it was significantly expanded, okay? But his jaw was not destroyed at the same time. You can see the extent of expansion, three-dimensional in the entire nasal vault. And he wanted to maximize his improvement. There you can see the bone, you see? So this remains the same. So I advanced him. And why? Because he wants, a lot of these people, they've struggled with breathing and sleep for their entire life. They've obtained improvement. They want to maximize their improvement. I advanced them, I think 16 millimeters, okay? What's interesting is that he told me the extent of improvement from his symptoms was greater with the ease with the nasal maxillary expansion than the advancement. That was actually surprising to me. Getting older, 34 years old, skeletal expansion, you can see a significant expansion without destruction of the bone or teeth. Much improved nasal breathing. Getting older, 37, sleep apnea. Initially, he went to see someone, they wanted to do an MMA on him. He's not the greatest MMA candidate. We won't go over, this is not the right arena. So I expanded him. You can see that pure bony expansion, front and back on a 37-year-old. You can see the suture can be manipulated when you're older. Pure bony expansion, much improved. Breathing and sleep much better. 37-year-old failed CPAP and oral appliance. You can see that his maxilla was significantly expanded. It's a very large expansion, probably about, I don't know, 6, 7, 8 millimeter expansion on the bone. You can see the changes in terms of the nasal cavity, okay? I treat a lot of women, always have problem breathing through her nose and was diagnosed with sleep apnea. Whole family has sleep apnea. She was expanded. You can see bony expansion without destruction of the dentoalveolar or the teeth. Breathing, sleeping much better. And I'm currently treating her husband. Getting older, 42-year-old. He had to go, he's from Chicago, but he has to go to Florida certain months a year because he just could not breathe through his nose. Okay. He was expanded. You could see a significant palatal nasal maxillary expansion. 40-some-year-old, you can see that there's no destruction of the teeth or the alveolar, but it's pure bony expansion, ANS to PNS. Initially, he was planning, you can see these are prior nasal, he had a bunch of nasal surgery, which never helped. Initially, he was planning to have an MMA. After this, he was done. Now, he's actually a patient of mine. 8 years prior to MMA, prior to the expansion, I did an MMA on him because I didn't develop this operation until about 4 years ago. So he has sleep apnea. 8 years ago, I did an MMA on him. I think my advancement was, I don't know, 14 or something. You could see a fairly decent advancement. He was much better, but he found out that I developed this operation. He came to see, he says, I want to improve further improve whatever symptoms I have, and I want to be able to breathe better. You can see after MMA, you could still expand, okay, front and back. you can still expand significantly. He's much improved breathing and sleeping better. Middle-aged woman, I'm treating the son, and she decided to be treated as well. Okay. Pure skeletal expansion, anterior posteriorly. I'm showing you a lot of cases because when I hear talks, I see some people show 1 or 2 cases and make people believe that that is the result of the surgery. You know, I think it's a bit of a sort of a bait and switch if you just show 1 case. Okay. You can see the significant bony expansion without affecting the dental-alveolar aspect. Breathing much better, getting older, 47-year-old nasal obstruction. He had multiple nasal surgeries, sinus surgery. He walks around with a breathe right strip. He was expanded. Skeletal expansion on a 47-year-old, front and back. He's much improved, wrote me a really nice note. Very happy in terms of his nasal. You know, it's plumbing, okay? You have to, when you're trying to improve the airway, you have to expand the nose. Sleeping better. Now 50, I'm treating her, I treated her son, so she decided to come in to be treated. She had some nasal obstruction, skeletal expansion, front and back, no destruction in terms of the alveolar aspect. There you can see pure bone expansion with nasal opening. 51-year-old man with moderate sleep apnea, a bit overweight. I wasn't sure if this procedure really is going to help him dramatically. I told him, at least you will breathe better. He was expanded. 51-year-old, no destruction in terms of teeth or dental alveolar, pure bone expansion, front and back. You can see the extent of expansion over time. Sleeping much better. Going to, he's a scout master. Going camping, doesn't need a machine, feeling much better. Getting older, moderate sleep apnea, 50-some-year-old. Expansion, ANS to PNS. No change in terms of the teeth. I treated her because I first treated her teenager son with sleep apnea. Even older, 62-year-old severe sleep apnea, I expanded her. You can see the extent of expansion. Skeletal without just creating a huge diastema. This is the old paper that I published. You can see the improvement of, mean age was about 30. Was able to open up the bone only, not the teeth. I don't measure the teeth, okay? Improvement of sleep apnea. The key is to expand the nose. So it's not the jaw, it's not the distance between the teeth. It is not the nasal floor, but the nasal sidewall. That's what we're trying to manipulate. Okay, that's what we're trying to manipulate, to expand the entire pyramid. Now, this is a paper that should be coming out this year, 100 patients. You can see that when I measure the nasal airway at the anterior nasal spine, at the molar and the posterior nasal spine area, this is the nasal changes. You also see the zygoma width increase a little. Why? Because it's really the entire midface that's being expanded. Okay, measuring the pressure, I looked at 20 patients. The mean age was 35. You can see that significant improvement in terms of negative pressure based on computational fluid dynamic analysis. Okay, so you don't have to generate as much sucking motion to breathe when you're asleep. Therefore, improves breathing, improves the ease of breathing, improves sleep apnea. Remember the 58-year-old had this whatever appliance that's put on her teeth. Basically, all it did was just flare out her teeth. Nothing changed in her nose, right? The suture is still intact. She was no better. Okay. I expanded her. I'm still expanding. She just, you know, in the middle of the expansion, but you can see she is opening up on a 50-some-year-old. She's breathing better and sleeping better already. This is before. So this, you can see opening up the mid-palatal suture on a 50-some-year-old. Remember this patient that came to see me from Denmark, had the AGA treatment, destroying her upper lower jaw, destroying her teeth, destroying the bone, not doing a thing. She was so symptomatic. I talked to her about expansion because she has significant nasal obstruction. She wanted to have the MMA. I did the MMA on her. She was much improved, but she still has problem breathing through her nose. There you can see what the appliance was doing, flaring out the teeth. I just told her to take off the junk. All the teeth reverted back. That's relapse, which what you want, okay? And I expanded her after the MMA, about a year after MMA, you can see the pure bone expansion with enlargement of the entire nasal area without destroying her teeth. Remember the 22-year-old guy from London? He had the MSE, was had a lot of pain because it was eroding his palate and bone. I expanded him. He was just here today. I'm expanding him. You can see the pure bony expansion front to back. He's just starting, breathing and sleeping better already, okay? And people will say, well, Jit, you just opened up a couple millimeters. That's right, because the extent of the expansion is entire nasal wall. You don't have to try to expand 10 millimeters. Remember the 30-some-year orthodontist that failed MSE? This is after MSE. You can see nothing has happened. The expander just eroded into his palatal tissues. I expanded him. Before, after MSE, you can see that skeletal expansion. His snoring's better, his sleep's better, breathing's better, okay? Remember the kid from Canada, 20-year-old who had failed MSE? I expanded him. There you can see no change in terms of teeth, pure nasal expansion, front and back, okay? In a lot of patients that I see, they've had expansion. They've had separation of the mid-palatal suture. They were told the expansion was a success. Well, it was, depending on your reference, but they still are symptomatic. They may be a little improved. They come to see me, but they're still symptomatic after expansion, after MSE. Well, yes, here's the screw. The MSE did expand, but the improvement was insufficient. So he had more expansion with the ease. I don't want to make you think that all other expansion is bad. You just need to understand the physiology and the data. Is there data supporting its use? I use MSE myself. It depends on the case. I'm very selective. Okay, this is my MSE. I do not attach onto the teeth. Okay, why? When you attach the appliance onto the teeth, you're going to basically flare out. It's kind of an angular rotational expansion. I want to expand the entire nasal volume all the way up to the nasal frontal suture. Okay, so what did I do? I first started the expansion with ease. Okay, because it's the hardest part. But he's from another state. He had problem manipulating the distractor. So I placed the MSE. You can see how you can still expand, provided that I was able to open him up with the ease, and that you continue to expand. I do this occasionally depending on the patient. Okay, you can see sequentially, you can get significant expansion. Now, you could get dramatic expansion with the ease. Not everyone needs that. Usually I see improvement of nasal breathing first, and then improvement of sleep comes after that. And I will continue to expand, and you will hit a plateau. Some people continue to improve, I will continue to expand, okay? But you can see the extent of expansion. And these are 30 to 40-year-olds that you could do this pure skeletal expansion, really manipulate the airway, improve their symptom and sleep. So you don't have to look like this in order to breathe and sleep better, okay? And just because you're recreating a huge diastema, that doesn't mean anything. We want to open up the nose, not create a huge diastema. Huge diastema actually is bad. I'm going to finish up on MMA because I've been doing MMA for a long time, done over 1,000 cases. This paper should be coming out probably this year. Now, there's a busy slide. So MMA is being done a lot now. You go to any sort of surgeon and say, oh, you need MMA because you have sleep apnea. This patient is a patient from France that consulted with me. He wakes up, cannot breathe through his nose. He wakes up every night, multiple times. But he says, in the middle of the night, I can't breathe through my nose. Saw ENT, set them straight. Nasal turbinate is not big. He went and had a big MMA, and he is worse. His nasal breathing is now worse. His sleep apnea is now worse, despite a huge advancement. He can't breathe through his nose, okay? I don't care how much advancement is done. You have to evaluate the patient. It's not blue plate special. Everyone gets an MMA. Another patient came to see me from Los Angeles. Same story. Problem with sleep, can't breathe through his nose. He's a bit better after MMA, but still symptomatic. Very narrow nasal aperture. Okay. So if you're going to risk significant facial changes, potentially compromising your facial aesthetic, you want to maximize the chance of improvement, okay? Now, on the other hand, I see the plates and the screw. Remember the dome complication and all those MMA complications? Same MO from the same source, okay? This patient had the MMA, was advanced 5-6 millimeter. Now that is not enough. Came to see me, still symptomatic. He had advancement, but he had a clockwise rotation, which impacted his nasal breathing, and a small advancement, no better. Same source, same minimal advancement, no better, can't breathe through his nose. I expanded him. He's about 25% into the expansion. I only expanded him 2 millimeter. He's breathing and sleeping better already, okay? So nasal breathing, nasal breathing, nasal breathing is not, it's a lot of times it's the jaw, but it's not always the jaw. If you're gonna do a jaw operation, try to do a good operation. You can see the patient after a poor MMA, you can see the expansion ANS to PNS. All right, I've done close to 400 cases in about similar numbers in children and adults. The success rate is not 100%. Nothing is 100%, okay? There's been a few that I couldn't expand. It's different reason between children and adult. In adult, some skulls are just so stiff, I couldn't expand. Now you can see that this is a mean age 35. It's up there. I had a few failures. Now in children, it's different. Usually failure comes somewhere around 10, 11, 12-year-old, that the bone is too soft, okay? Because I need some stiffness of the bone to be able to expand against, so I can then manipulate the midface, okay? Usually that's what happens.